Co-lead of this of the Guinea case study with Dr. Pate, who is not here. He's in Guinea. He's former Minister of Health, actually, in Guinea, but he has a very strong passion for pediatric palliative care, actually, and has been initiating some new programs in the country. And we also have, as co-investigators on this particular case study, Matthew Hunt, Kevin Bazansen, Alpha Diallo, who is a health researcher, public policy and health expert in Guinea, and Umu Basso, who initiated the first TB program and is an expert in tuberculosis care in Guinea. So very diverse perspectives, and Sekou Kouyaté, who conducted the interviews and has been instrumental to analyzing as well. So for the Guinean case study, our focus was to pay attention to the exceptionality. We wanted to do a case study on Ebola and palliative care. And since it also was quite opportunistic in the sense that we were traveling to Guinea already and working with Guineans through our other study. 5 main themes have emerged out of the 16 interviews we conducted with local healthcare providers, as well as survivors and family members of individuals who died in Ebola treatment centers during the 2014-16 epidemic. So those are the uniqueness of death, dying, and care in the Ebola virus disease context, role of family and non-healthcare professionals in the provision of care in treatment centers, the importance of witnessing good palliative care is just good care, and dying in honor. Due to the limitations of time, I am going to be focusing on the uniqueness of death, dying, and care in this context, as well as dying in honor. But we'll certainly have time to discuss other aspects after, I hope. So in terms of the uniqueness of the EVD context, or the exceptionality of this context, what is very different about death and dying in the context of Ebola, first of all, is the omnipresence of death and dying everywhere, as well as the terror and fear that was widespread, the rumors about who is causing the death or what is causing the death, with layers of theories of conspiracies and infections being intentionally propagated, and hexes. There was other factors as well that are very particular, which is that because of all these fears about what is causing it and fear of infection, there's also secrecy around death and secrecy around the risk of infection, which is presumed to lead to death. And that is very particular in the context of Guinea, especially where when somebody dies, it is a huge public known event and certainly communicated very quickly. So we heard tales of people hiding, and getting rid of bodies secretly at night. Distrust of Ebola treatment centers was widespread, and yet the only place where you really could get any kind of health care. And again, that's exceptional to the Ebola context because of the high infection level 4 pathogen, and the economic devastations that come from the death because you have entire families wiped out, as well as losses of homes, losses of jobs. If you're in an Ebola treatment center, perhaps you survive, others have died, and you no longer have a job. Ebola, the exceptionality of palliative care in the Ebola treatment centers, there are many, many elements. Certainly there's the very proximity, the sounds, sights, smells of suffering and dying, which are described at length by our participants. The proximity of the dead, so usually often within sight, in terms of the morgue itself, or where you're taking the body out, but also, of course, people are dying next to, they will be watching their neighbors die in all cases. And healthcare providers as well are in constant contact with the dead. Limited knowledge of disease and diagnostics makes it that much more challenging, of course, to kind of figure out who might die, so that you never really, there's no clear understanding of what symptoms meant, or at least evidence-based understanding. And then a huge particularity of palliative care in this context is the limited patient healthcare provider contact. So very limited time in the Ebola treatment centers. We heard about that yesterday from people who were there. Recommended time is 50 minutes to an hour. People push that to 2.5 hours, sometimes 3 hours. But the fact is you have many, many patients And so often what we're hearing in the narratives is that they came in, they gave food, water, medicine, and that was it. So very limited patient healthcare provider contact, especially at the beginning. In terms of the patient perspective, additional factors that were particularly emphasized, and I guess all of these kind of cross-cut the narratives of either patients and family or providers, but the generalized loss, so people are already coming in mourning the dead, and then they're at risk of dying and sometimes dying. That's very particular. Huge amount of anxiety, certainty that you're going to die, unpreparedness for that, and yet depression. So often the focal vision of I'm going to die comes across in those who survived. No traditional post-mortem rituals, so no prayers. The initial body bags being black as opposed to having a white covering. The fact that the body is exposed for everybody to see, which is not common. The isolation, of course, you're not with your family, you're not with your loved ones, which would be, the tradition is that people would come and visit you and be caring for you. The people that you care about are caring for you at the end. Patients stressed and sometimes were angry due to the limited healthcare presence because the expectation is that if you're going to a healthcare center, you're going to get healthcare from providers. So even though there was also acknowledgement of the limitations of, because it's an Ebola situation, and acknowledgement that there's just so many patients, they really recognized that this was overwhelming for healthcare providers. They also felt that lack of presence was a huge problem. What matters most was a question that we asked. What matters most to, we had two sets to the interview. We went more general in terms of in Guinea in general at the moment of death and dying, but then also if you were dying in an Ebola treatment center, what would you want done for you? And so what comes across there is the huge importance of psychosocial support that was emphasized, which connects to that need for presence and kind of the overwhelming suffering that comes from the isolation, from the lack of contact, from being cut off from family, not to mention perhaps permanent loss of family for people who are in their last moment in the ETU. Economic support to the bereaved has been mentioned a couple of times, and I should say this is preliminary, so 7 of the 16 interviews have been quoted at this point. But yeah, this is again something that resonates in terms of those who have worked in other African contexts. Economic support to the bereaved is part of palliative care that's very important. So something to kind of think about what palliative care means in these contexts. It can definitely encompass at least addressing the complexities of legal inheritances, or people are going to have to deal with all these complicated issues. And dying in honor is the biggest thing that comes across, and that is unique for us looking across our case studies. This idea of dying in honor. So there's many layers to this dying in honor, but it's a phrase, mourir dans l'honneur, is something that a few participants said specifically, and then there's also a lot of emphasis on providing dignity to the patient as they're very sick, by being present, by making sure they have what they need, by making sure they feel like they are cared for. And they have to be cared for from the heart. So we had other questions about, does it matter, the nationality of the provider? And for many it does, for some it doesn't, but for those who it did, it was because a Ghanaian would be caring not only as a professional duty, even though there's no complaints about the expatriate care provided, but they said, but a Ghanaian will be caring for me like a brother. They'll be caring for me out of their heart. And so that was very meaningful, and to have somebody caring for you out of their heart, whether it's, sometimes it was fellow patients, or family members, but also in terms of the providers, that was quite meaningful to people, and allows you to die in honor, because to die, otherwise you're dying abandoned and isolated. Respectful treatment of the body after death, which is not having the body exposed to any prying eyes, making sure, and something that still needs to be clarified in dialogue with the Ghanaian co-investigators, is this emphasis on healthcare providers have to be able to hear the last secrets of the dying, which are more at the end. In Guinea, the tradition is that you're going to share critical information about inheritance, and about who should do what in life, sometimes recommendations about who should marry whom. This is, I was clarifying this with Siku. But then the other thing is that when the body is being taken out, there might be secrets revealed through the body that I don't understand yet, but the healthcare provider should be able to keep the secrets of what they see on the body. That I have to clarify. But that was something that people had heard was not being done in Ebola treatment centers, as well as a lack of understanding amongst some of what happens to the body after. So with all the rumors, that was an additional stress on people. I guess I haven't said much about the support of that. Well, great, because I'm not allowed, it's true.
Okay. More than 5.
Yeah.